So the first questions when a woman is pregnant in the context of endometriosis, if does endometriosis increase the risk of fetal loss? So we are going to discuss the last meta-analysis of Blandine, and you will see that some conflicting results concerning pregnancy outcome, and it's hard to do the difference between the direct impact of endometriosis or the impact of ART and endometriosis. And we can ask ourselves, do all stages and types of endometriosis increase miscarriage? And is there specific impact of the ART technique on pregnancy outcome? So, in non-ART pregnancy, we have two meta-analyses with different articles inside, and we can say to women that endometriosis doesn't increase the risk of miscarriage in case of spontaneous pregnancy in endometriosis. However, if we try to understand all the figures of this meta-analysis, we will see that there is conflicting results depending on the type of endometriosis and the type of included study. And what we see is that after ART, endometriosis increases the risk of first trimester fetal loss. However, when the statistics are done with adjustment for maternal age, you see that high heterogeneity of this meta-analysis. Oops, sorry. What happened? We see high heterogeneity of the included study, and this high risk of miscarriage is at the limit of significativity. In this meta-analysis, all the phenotypes of endometriosis would increase the miscarriage rate with significantly risk. But what we have to take home is that adenomyosis is probably the key factor for the risk of first trimester of miscarriage, with, as you can see here, 3 with a risk increase by 3 by 4 of fetal loss. And you can see here that the risk is increased by 4 in case of endometriosis associated with adenomyosis, with here a low heterogeneity of the meta-analysis and a significantly higher risk. If we look at this meta-analysis, the study reported a higher risk of miscarriage after antagonist or short agonist protocol. However, if we look the long agonist protocol, you see that miscarriage rates are similar with ultra-long protocol compared to agonist protocol. If we want to study the third trimester pregnancy complication, please go to this meta-analysis. There is so much figure that I will try to understand the main results. And what we have to know is that endometriosis is an independent risk factor for placenta previa, in addition to the risk already confirmed by IRT pregnancy. You see that all types of endometriosis after natural conception, after IRT, and especially in case of deep endometriosis here, there is a very huge higher risk of placenta previa. And adenomyosis is also a big risk factor for preeclampsia, with a higher risk increased by 4. Why? There is some hypothesis. Adenomyosis would alter uterine contraction, and so the placenta accreta would be increased by affecting the location of blastocyst implantation. Moreover, endometriosis will be associated with inflammatory cells in endometrium and intrauterine oxidative stress, so leading to maternal endothelial dysfunction and abnormal trophoblastic invasion. But is it the chicken or the egg? Because is endometriosis the cause of obstetric complication, or is it the underlying chronic inflammatory condition that leads to both endometriosis and obstetric complication? There is growing evidence that endometriosis is a systemic disease and not only a pelvic disease. If we study the other complications, we know that severe endometriosis is associated with a higher risk of fetal growth restriction, preterm birth, and C-section. However, in the studies, there is no data concerning the etiologies of the prematurity. We don't know if it is spontaneous prematurity or induced prematurity for maternal reason or fetal reason. So we don't know if prematurity is due to prepartum hemorrhage, to preeclampsia, or to fetal growth restriction. To sum up all these figures, you have to take home this data. The risk of miscarriage is increased by 4 in case of adenomyosis. The risk of placenta previa is increased between 6 and 14 in case of severe endometriosis and deep endometriosis. And moreover, there's a risk increased by 3 to 3 in case of severe endometriosis and deep endometriosis. In the literature, we can find some uncommon obstetric complication and unpredictable as spontaneous hemoperitoneum in pregnancy due to adherence, and you can have a hypovolemic shock in this woman with a high rate of maternal mortality rate and neonatal death rate. It has been also described bowel intestinal perforation during pregnancy and uterine rupture. We can think that surgery before pregnancy could reduce the risk of endometriosis-related pregnancy complication. However, it's not a good strategy. As we can see in this Danish cohort, in this sub-analysis, we know that women who had endometriosis surgery have also a higher risk of placenta previa and preeclampsia. But the bias of this study is that surgery is a marker of a more severe disease. Of course. During birth, it's still not over. it has been described a higher risk of postpartum hemorrhage for all endometriosis stage, and especially in case of adenomyosis associated. And the C-section is also have also higher risk of hemorrhage, hysterectomy, and bladder injury, especially when there is a deep endometriosis associated. After pregnancy, it's still not over, because the evolution of endometriosis is unpredictable. As you can see in this French study, they observed the evolution of nodules during pregnancy, during a hormonal contraception, and during treatment with amenorrhea. And you see that even during pregnancy, the author reported evolution of the nodule. So we have to end with the myth that pregnancy cures endometriosis. In the study of Alberico and al., they describe the reappearance of one less symptom of severe intensity in 84% of women after pregnancy. As we reported in this qualitative study, we know that there is a lull period, but the symptoms reappear if you don't have a hormonal treatment. And a lot of women thought they were cured by pregnancy. So to conclude, we have to communicate between IRT center and obstetrician and midwife, because